Yeah, so last 30 minutes, just bear with me. Okay, so in this talk, I'll just bring through what are the major cases, or what are the major categories of cases that we see with some examples. Then I'll talk about the common challenges that we face. And after that, if we still have energy, I'll bring you through some of the cases that you might find interesting. So this gentleman came to me. He has got a right leg swelling, right leg. So I asked him, what happened? And he said, I jumped down from the lorry, then I sprained my leg. Then something came to my mind. So last year, there was this news, foreign worker sues company for 100,000 in damages after fracturing leg. He jumped down. So this was last year, August 2023. I was still with the polyclinic. So I didn't put a lot of thoughts into it. But I just want to show, this is the lorry that they usually use to transport the workers. So they should step here and then come down. But imagine that they usually just jump down, without stepping on this step. Other than that, this lorry, it's not only they use to transport the workers, they also transport equipments, building materials, sometimes detergents, chemicals. And if let's say they have one emergency brake, all hell break loose. So for this gentleman, I examined him. He's quite okay. No bony tenderness. He's able to bear weight. So I give him some medication, give him MC. But as a caring doctor, I still offer him an X-ray so that he don't miss out on his 100,000. But there wasn't any fracture. Followed by this case. So this gentleman came to me with facial injury. There's a bump on the forehead, some abrasion, some bump on the face. So I asked him, what happened? So he was sitting in the center of the lorry. The lorry braked, he flung forwards, then his face hit on the backboard of the driver's seat. He does not have any head injury red flag sign. So I just asked him, what time was the event? He said, 5:20 a.m. I said, so early? I just divert a bit. So usually he need to wake up 4:45 a.m. He need to be on the lorry 5:10 a.m. He reached his workplace at 7 a.m. He worked until 7 p.m. He wait for the lorry pick him up, will drop a few places. By the time he back to his dorm, it will be 11 p.m. He cook, he eats, he bathe. By the time he goes to bed, 12:30 a.m. The next day, 4:45, he needs to wake up. 6 days a week. Why am I telling you this? These folks, they are just prone to illness and injuries with this kind of schedules. So anyway, he's fine. I also offer him an X-ray. He declined the X-ray. He said he's okay. So I gave him some medication, gave him MC. So the first major category of cases that we see is musculoskeletal injuries and pain. The reason why I put up lorry-related incident is not because it is particularly serious, but rather I think it is something that we overlook, something that I have not thought about it before. So I choose to just put it up. So the second category of cases that we see, this one a bit slower. So this one, very commonly seen, fever, headache, body aches, vomiting, high fever, 38.7. So what do we do in clinic? So our clinic, we do a lot of this. If you look at our shark bin, it will be full of this. So you just look at the right side column. This is dengue NS1 antigen, so positive. IgM, IgG are not present yet. So dengue with the vomiting, dengue with warning sign. Blood pressure a bit low, we set up IV drip, we activate 995. So second category of cases that we see, ARI. No surprise there. And the third major category, and I think it's a growing category, it comes something like this. So this gentleman came to me, right shoulder pain, slight chest pain, and in their words, they use something pain. They move the hand, it will be pain. No move, no pain. So we check him. His right shoulder is fine, full range of movement, no bony tenderness. Right chest rib, no pain. Blood pressure a little bit high. So as a caring doctor, we order more tests. So we order ECG, just quickly show you. The lateral leads, some T inversion, ST depression, the same for the inferior leads. So we sent him to the ED, and he was admitted for MI, high cholesterol, high blood pressure. So the point is, he will be coming back to us for follow-up. So the third category will be chronic illnesses. Not all of them come with MI. Sometimes we detect them from pre-employment check, headache, we check blood pressure, high blood pressure. Sometimes they just go for a holiday, do a health screening, come back with coronary artery disease, whole list of medication, then we will follow up him. So these are the three major categories of cases that we see, and they probably cover more than 50% of the cases that we see every day. So next case. So this gentleman came to me. Then he said, "Doctor, spicy makan, mouth, many pain, 3 days no makan." So just take a look. So he has got a huge ulcer. In fact, the whole mouth is full of ulcer. And his tongue has desquamation and very inflamed. Then he also tell me, "Doctor, I also got something on the hand." So you look at these white lesions. So these are blisters, painful blisters, and he has it generalized, whole body. So when we see these kind of cases, he's otherwise well, no fever, little bit cough and cold, his vitals are all stable. So when we see this type of generalized skin reactions, we need to take a good drug history. So I asked him, "Any medication are you taking?" They say, "No medicine." Supplement, vitamin, nothing. Powder, soup, from friend, from family, nothing. I wasn't very sure what was going on. So as a caring doctor, I just tell him, "I write you a letter. I think you better go to the hospital and check. I don't think this is good. It seems very dangerous." They say, "Hospital? I just came back from hospital 5 days ago." They say, "Hey, why? Back pain. Then any injection, any medicine?" They say, "No medicine. Pain tablet have." So he was given Acoxia and Tramadol 5 days ago. He started taking that 4 days ago. Then 3 days ago, he started to develop symptoms. Anyway, he still need referral because he can't eat. So it's Stevens-Johnson syndrome due to Tramadol. So this case is to illustrate the challenges that we face. The number one challenge will be communication. Patient-doctor communication. So we can easily miss a very important piece of information. In this case, it's the drug history. Not only in terms of languages, as well as culture, the expectation and concern. So patient-doctor, like in your clinic, when you talk to your patient, there's always a gap. But the gap is wider in migrant worker clinic, and we are working hard to bridge the gap. And secondly, to bridge the gap, we need time, so time constraint, just like all of your clinic, right? Who doesn't have time constraint? Introduce me later, your clinic, no time constraint. All right, so actually these are the main message of my talk, the major categories of cases that we see, and what are the common challenges. If you still have the energy, I just bring you through a few more cases. So this gentleman came to me, a tumor on the left upper eyelid for 1 week. Little bit pain, little bit itchy, getting bigger. You see the tumor? Can see or not? So what should we do? What is this? Refer eye? Remove the tumor? So we remove the tumor in the clinic. The tumor can run one, What is this? It's a tick bite. So this patient represents a subgroup of patients that we see, which is bites. Tick bite, spider bite, cockroach bite, bee sting, Mickey Mouse bite. We have all of them. So every time I need to scramble to Google, what is spider-borne disease, and whole list of disease come down. I never see any of them. So in this case, CDC say need to give 1 dose of doxy, so we give for Lyme disease. Never seen one before also. So this gentleman came to me, 2 days of ear pain. You open the ear, you look at the white thing, you probably know the diagnosis already. Outside of MW clinic, I probably see once a year. Here, I see every week. So inside, I find it very difficult to take picture inside the ear. Very challenging. I take a lot, cannot take. Then last one, I managed to take. What is this? When my daughter saw this, she asked me, Daddy, why there is dandelion garden in the ear? So these are the, she always like to vandalize the PCN, go and pluck the dandelion. So these are the spores, and with the hyphae. So this is a fungal ear infection. So we give topical antifungal. If we detect perforation, we give oral antifungal. So just be careful. Don't accidentally give antibiotic ear drop. Can give or not? What will happen if you give antibiotic? The garden will become a forest. All right, so back pain, flank pain, we see this very often. Order a dipstick, a lot of time they got a bit of blood. Then we order X-ray. Okay, my phone not very good, my camera, but you just imagine, on the right side of the spine, there is one white opacity. Cannot show one. Anyway, this is urinary calculi. So less than 5 mm, always they will come out. Less than 10, we usually just observe, repeat, give some medication. More than 10, no need to wait, we can refer. This one, you see just now. So tinea, not uncommon outside of MW, but if you want to see extensive one, you need to come to us. This is eczema. Different form of eczema on the hand. Some is more on the dorsum. Treatment are all the same. Steroid, find out the cause. Hygiene advice. Okay, this one. Before this, no one come to me for dental problem. But when I start working in SATA, I need to start to study dental problem. So it come a dental pain. So this one on the, hey, this one. Anyway, yeah. So these are retained root. I'm not a dentist. This one I Google one. The picture is real, but I Google the diagnosis. So these are retained root. When you have a lot of caries, the tooth is all gone and it becomes a retained root. And the second one is chronic gum disease. And in this case, it's periodontal abscess. I still remember he told me, Doctor, yellow water whole day coming. When I open up the lip, the pus is just flowing out from the lower gum. So we need a lot of help from the health serve dentist. And I always tell them, you need to brush teeth 2 times a day. Put a lot of toothpaste, brush every day. Then you gargle with Listerine, or then we give pain control, we give antibiotics. These 2 pictures I always keep in my phone. When my daughter doesn't want to brush teeth, I show her this. Then she will go to brush. All right, let's go to some mild work injury. So let's play a game. It's called Find the Foreign Body. Outside of MW clinic, I probably see this 1 or less than 1 per year. In MW clinic, I see it almost every day. Oh. Can find or not? On 7 o'clock, yeah. So on that day, 3 patients came, so I just take all 3. Next one, just play a game, just find a foreign body. Can find or not? So grinding and welding, debris fly into left eye. Can you find it? I find it difficult to find, I find it challenging to find. Maybe I got high myopia, too hardworking already. Here, 10 o'clock. 10 o'clock. Okay, last one. Hardworking, watch drama, don't think about other things. This one, he told me, dust went into my eye. I told him, dust never mind one. But he was dead sure that there is something in his eye. So you try and find. This one is quite difficult. This one is at 3 o'clock, this one. So when we see a foreign body on the eye, we use a blue needle, point away from the eye, we try to remove it. To be honest, if it's on the cornea, as a caring doctor, I let the expert do. On the conjunctiva, I can attempt. On this, usually I ask them to go to the hospital. All right, just an introduction to my clinic, or rather the road in front of my clinic. See on the right side, this one, this is the dorm. One of the best dorm in Singapore, S11, because they got a caring doctor there. There's an industrial area here. What I want to show is the dust in the middle. The dust in the middle. Every morning, when I cycle through this path, 100-meter path, I need to wear my hat, wear my mask, squint my eye. Then I cycle through this. If not, more than half of the time, a sand will stuck into my eye. What I want to say is, when they say dusty, it is dusty. All right. So this gentleman, he was asked to hack a kitchen. So he hacked the kitchen tile. Use the hacker. So one of the tile burst, and the debris hit on his right hand. Immediately he feel pain, numb, and weak. There's only one wound. The wound is at the medial side of the arm. The wound is less than 1 cm, and he started to bleed profusely. So the wound is here. So he went to one of the neighborhood clinic. The doctor gave him antibiotic, dressed the wound. And he said, see back in 2 days' time. Then he continued to feel pain, numb, and weak. So he seek further help. So X-ray was done. So there was a foreign body. Look at the location of the foreign body. It is on the ulnar bone. So hospital admitted him and removed this small piece of thing. And he came with... So he came with this. So he has got ulnar nerve injury. So he has got a claw hand. He has numbness over the lateral part of the hand. If given enough time, his small muscle will start to shrink. So good for a short case. In a short few months in SATA, I got ulnar, I got median, I got radial. You like to see this thing, come and join us. This one, spot diagnosis. So he injured his left index finger about 4 days ago. Just a small injury. But I continue to feel more and more pain, more and more swollen. What is this? What sign is this? This is carnival sign. So carnival sign shows tendon sheath infection. So the finger is slight flexion and there is fusiform swelling around the injury site. You press on the tendon sheath, it will be painful. If you extend the finger, it will be even more painful. With the presence of pus, it is pyogenic flexure tenosynovitis. So what is the significance of this? So carnival sign, there is 2 types. First type, you send for debridement. Second type, you regret you didn't send for debridement, so please send. All right. Yeah, so from the palmar crease to the PIP joint, this area, just remember it is called the no man's land. Any injury here, think twice before you discharge him. And then usually they'll need to do a Brunner's incision, the zigzag incision. All right, so we always ask them, what's their work? So this one, they cut your grass in front of your HDB. So they get cuts, they get tick bites, welding, they get eye injury. This one is quite common, called rebar. So I learned this metal bar is called rebar. So they say rebar working, rebar carrying, rebar tying. And one of the workers told me, he do gondola. I said, Singapore have meh gondola? Singapore River. So these are gondola. So they use this gondola to clean the HDB. Yeah, so nice. Okay, so just pay attention to this picture. So this worker, he's cleaning the window. And there's a pail on his right side. So he need to dip the detergent. Then he go and wipe, dip, wipe. What could go wrong? So this worker, he dip, wipe. The detergent dropped on his protective cloth. It burned through the trousers. So chemical burn. We see this a lot. So we dress until they all heal before they go back to work. So what's the lesson here? I don't know about you. When I see someone doing something now, I run far away. If this one drop on the face, then how? Yeah. Cement burn. So they burn through the trousers, same thing, but there is boots there, so they spare the lower part of the leg. Okay, this one a bit unique. I heard about it, read about it, but this is the first time I see it. You want to guess what happened or not? I learned about one new word from social media. It is called hold, not H-O-L-D, H-O-D-L, hold on to dear life. So he was assailing from 15th floor. He lost footing. He started to fall. The only thing that he can hold on is a rope. So he hold on to his dear life. Guess which floor he stopped? So from 15th floor, he stopped at, I think it's 8th floor. So he fell 7th floor. So he hold on to the rope. So this is rope burn, friction burns. The treatment is the same as any kind of burn. So this wound is about 1 week plus old because he was admitted for the first 1 week and first 1 week plus. So we continue on his dressing. All right. Well, this one, this is a 60 kg metal bar. When one of the workers tried to push up the metal bar, and someone on top of on the ground tried to grab it, but he lost footing. Again, he fell. Then the metal bar fell on him. So he fractured his spine. So fractured spine, T4, no paralyzed, but he has got sciatica after that. So he's undergoing aggressive physio and occupational therapy. He's doing fine, but I lost follow-up for this patient, so I don't know what happened after that. All right, so in summary, so the three major categories of patient that we see: pain, ARI, chronic diseases. Major challenges, communication and time constraint. Okay, last one. Before I end, please allow me to just share what I have learned over the last short period in SATA. So this gentleman came to me, a very normal patient. So he told me, "Doctor, I got right shoulder pain." So I checked his shoulder. This type of wound, very commonly seen. So this gentleman, he said, he carried the rebar bar, so he abrased his shoulder. If I accidentally press on the wound, he would jump. So I tell him, "Oh, brother, I give you MC, I give you medication, then you rest." Then he told me, "Doctor, no need MC." I said, "Why? So pain. Why no need MC?" Then he said, "Doctor, 16 people waiting salary." So what I have learned so far is this shoulder, not only shoulder their work, the metal bar, not only shoulder their livelihood, their family's livelihood, they also shoulder their family's extended family's livelihood. And they also shoulder the comfort that you and I have today. Thank you.
Thanks so much, Peng, for the very entertaining and caring presentation. So it's quite an exciting and challenging place to work in, migrant worker clinic. So I'm sure I'm happy that you're enjoying your patients every day. Any questions for Peng? Yes.
Sorry, me again. I'm not really asking questions, but I really share passionately that how you have shared with us this. Because before I joined home, I actually worked in the shipyard for 4 years. Yeah, I climbed up and down in the ship, in the vessels with all the workers. So I can really tell you, right, in the shipyard, it has accident every day, literally every day. Yeah, but the shipyard runs the place like concentration camp. They have their own medical team, ambulance, and all that. So, and the shipyard doesn't like contractor to report their work injury. So there's a lot of injury actually being suppressed. Yeah, not able to report. So that's what actually inspired me to do something. So I end up at home. Yeah, you know. So I think I really I'm very happy to meet you. I'm glad that I didn't left this room earlier. I was thinking that no, maybe I can go off early, you know. But thanks for your sharing, and I will tell all the workers next time, sir. If you can, try to ask your boss to send you to stay in S11. There's a caring doctor over there. Thank you very much.
Thank you. Any other questions? Yes.
Okay. Hi, I'm from TWC2, Transit Workers Council, an NGO. We also see a lot of migrant workers coming to us with injuries that were not treated properly. And one of few cases I've seen, a worker who were treated at SATA clinic or other GP, workers tell us that even though he had a serious injury, he didn't ask for MC. And when we ask why, and he says, because if I get MC, my boss will not pay me overtime. So he told the doctor, please don't give me MC because of this reason. And then doctor will say, okay, I don't give you MC. And for this reason, he will lose the MC entitlement, MC wage entitlement for like 2-3 months. So, what would you suggest, as a doctor at SATA clinic in migrant worker dormitory, if a worker says this without knowing that he is waiving his legal entitlement to MC wages?
Sorry, meaning he will be given MC, but no wage.
No, the doctor suggested to give him MC,
Ah.
but he declined because he was worried upsetting the employer and losing part of his salary.
Oh.
And then doctor agree with him and does not issue MC. And later on, he files a work injury claim for that injury, and then we realize that because of this, he has lost like 2 or 3 months of MC wage entitlement. So as a caseworker, we hope the doctor would tell the worker, I can still give you MC, but you don't have to show it to your employer until it become necessary. Because the employer will not find out that he got an MC, right? Unless the worker volunteers it.
I see. I don't have an answer to that, but I can give you my thoughts. Number one is there has been cases being brought up that insufficient MC, and the doctor got into trouble. So he was banned for, 6 months or something due to insufficient MC. So at least after that, I think a lot of us are more careful to so-called not giving in to the employer. So I think we are more careful in this aspect. That's number one. Number two, because we are using this PCP, unlike before, when I worked in the GP clinic before this, the employer will be there with the worker, and the employer will sort of hold the money or the approval sheet. It's my company that's paying you. So if we work in those situations, we are in pressure of giving in to the employer. So in this aspect, I think PCP, we remove this factor that we do not need to say, listen to the employer. We are fully answerable to the worker only. So I think we are going to the right direction right now, and I hope things will get better.